Our POCUS theme this morning. It is my great pleasure to introduce my colleague and friend, Dr. David Lewis. David is a full professor of emergency medicine here in the Department of Emergency Medicine, Dalhousie University and Horizon. He is well known in ultrasound circles, as well as golfing circles, of course, here in Rothesay. David is the former chair of the CAPE Ultrasound Committee. He is an author he is an editor of a textbook, Point of Care Ultrasound in Resuscitation Emergency Medicine, and he is also a contributing author to many other publications and other textbooks. He's one of the founding co-directors of the ECU course and CAN POCUS, and he now heads up our POCUS fellowship here in St. John. So we're very lucky to have David here in St. John. He's a world-class leader, and he's going to tell us a little bit more now about another new skill with ultrasound, transesophageal echo. Thank you, David.
Thanks very much, Paul, for that introduction. You know how modest I am. It makes me feel very embarrassed hearing all those words. So anyway, without further ado, can you hear me, Paul? Yeah, okay. So I'm going to introduce a case just to start off this presentation. So you're the charge doc in your hospital, and a pre-alert comes in. It's a code blue. 50-year-old male witnessed cardiac arrest. They've got CPR ongoing. No shocks are advised, and their ETA is 5 minutes. So the team activation goes out over the tannoy, and you start getting your kit together. So here we have our crash cart. Our team is assembled, and the LUCAS device is ready to go. Obviously, those watching these rounds will know there's something missing there. I won't take questions at this point, but the first thing that I'm asking for usually in codes is the ultrasound machine. And there is actually our own ultrasound machine there, or at least a picture of one similar to it. And we want to get that into and ready because we know that ultrasound helps us in cardiac arrest. There have been a number of studies that have shown this, not least studies that have originated in our own department, showing the utility of point-of-care ultrasound in cardiac arrest, both for prognostication and also ruling out reversible causes. So this is our patient. They're arriving pretty soon. They're coming into the hospital. And I don't know what you guys are thinking, but the first thing that I'm thinking is, how am I going to get a probe on that patient's heart? LUCAS is all well and good, but it doesn't really help us get good ultrasound images. It's good for the patient, but not so good for POCUS. So the recommendations are that you're going to use a subxiphoid view for patients in cardiac arrest when a LUCAS device is there. So we do the ultrasound, and this is what we see. Okay, and that's how long you get in terms of viewing that scan before you're sort of pushed away or the LUCAS device slips. I'm not sure if anyone actually made a diagnosis in that brief clip. If you didn't, I'm going to show it a little bit longer. And feel free to type the diagnosis into the chat if you can see it. So that's about 10 seconds, although CPR is actually ongoing here. So you have got a little bit longer. But just for those of you who haven't spotted it, here's the heart, and it's surrounded by this large echogenic collection within the pericardial sac. So this is a hemopericardium, and presumably that's the cause of the cardiac arrest. Okay, so it's not easy to do cardiac ultrasound during CPR. So what about waiting for the pulse check? Well, this study, which was highly cited and discussed and tweeted from Resuscitation back in 2018, found that point of care ultrasound during cardiac arrest was associated with prolonged pauses during the pulse check. And they found that for those with POCUS, the median time for pulse check was 17 seconds. Without POCUS, it was 11 seconds. And interestingly, and probably, it sort of rings true, these times were worse when it was the code leader performing the ultrasound. I mean, really, this paper, I think, generated more interest probably from the results than actually the quality of the paper. It was a single center study with less than 100 patients, but they were real cardiac arrest patients. So this was followed by a paper published really just this year, but the work was done a couple of years ago. Some of you will recognize this study because we were actually involved in the study here in St. John, and Mandy Peach was involved in this during her fellowship with us here. And this showed that this study used actually 3,000 views on real patients. They weren't in cardiac arrest, and it compared the parasternal long to the subxiphoid view. And they found that in over 50% of patients, echo was able to achieve an image in less than 10 seconds. The median time for parasternal long was 8 seconds, so 8.8, and for subxiphoid 9.3 seconds. But bear in mind, these weren't in cardiac arrest. This was an experimental situation. I do have it on good authority that our own Peter Ross was responsible on his own for reducing the median time by at least 1 second during that study. So congratulations to Peter on that. So parasternal long is better than subxiphoid, but there's an issue with parasternal long, especially when you have the Lucas device in place. As you can see, you really can't get a great image with the parasternal long. You're going to have to sort of take it off. So it's not really doesn't help that much. And by now you probably all have seen this study, which has just been published recently, the double sequential defibrillation study. So this is where you have 2 defibrillators firing off one after the other. And it's actually, although again it's a smallish study, highly cited and talked about in the press at the moment, as not only was it called the double sequential fibrillation, it also appears to have doubled the survival rate in these patients with refractory VF. But the problem for us POCUS users is that the already sort of small area of real estate for ultrasound windows on the chest during cardiac arrest is now being taken up by even more defibrillator pads. And pretty soon there's going to be not a single window that we can access. So without a window, is that the end of ultrasound in cardiac arrest? Well, there is another option, and that of course is resuscitative transesophageal echo. And here's a physician next to the patient. So this is the airway physician, or the RT, and then the echo physician is standing next to them at the head end, and then the screen is there for everyone to see, including the code leader. So didn't we hear about this back in February 2020, I hear you all say? I thought we were introducing this 2 years ago. Well, something happened 2 years ago that kind of changed everything. In fact, March 2020, we had a little hiccup in our plans, especially for something that involved getting close to the airway. And also, I have to say, I did underestimate the amount of red tape involved in getting a program like this off the ground, as you'll see a little bit later. So just a quick look at the evidence. Well, there is a growing amount of evidence for resuscitative TEE. The first sort of study, I guess, or case series, Blavis back in 2008, presented a number of cases. His first case, 35-year-old PEA, failed parasternal views, They're about to give notice for calling code. They did a TE. They noticed a ejection fraction of 15%. They started pressors. He went to ICU and was discharged home. His other case was a PEA, a obese patient. Again, they didn't get great views. When they did TE, they noticed fine VF and they shocked the patient and got ROSC. This was the third case was a patient who had ROSC. So they put the TE down. They were doing post-ROSC care on the patient. The cardiac monitor was showing sinus rhythm at 60, but simultaneously the TE showed the heart actually slow and go to standstill, and they recommenced CPR on the basis of the TE and not the monitor, which is what we tend to do at the moment. And then finally, they had a case of a query PE from history and presentation. They were in PEA. They were planning to thrombolize the patient. They did a TEE, and the diagnosis was actually an aortic dissection. And this is a TEE scan. This is a mid-esophageal two-chamber view. And I think you can all see this flap in the aortic root here, consistent with an aortic dissection. So that obviously changed their management. And the themes from that study were or rather that case series were transthoracic views are poor in cardiac arrest in general, that cardiac monitor and pulse check can be unreliable if used alone. And we saw that in our own shock study when adding POCUS to ECG improved our prognostication. And so this study here, he quoted a couple of studies when he made this statement. One was that a study which showed in patients with asystole on a monitor, 35% had coordinated contractility. So this is a pseudo PEA, pulseless no ECG trace, no pulse, but actually some contractility on ultrasound. And then the pulse check is notoriously inaccurate when just done for 10 seconds. He noted that there was unexpected pathology in some of his cases. He noted that continuous cardiac monitoring during CPR and during ROSC was useful. And he also noted that there was a reduction in CPR interruptions. So, like in any good emergency medicine innovation, once we've done the sort of proofs of concept case series, the next thing we tend to do is do some studies to see if we can actually learn how to do this innovation. And a couple of studies came out after that, which demonstrated that you could teach people how to do, emergency physicians how to do this, this modality. This was a study looked at the 4-view resuscitation competencies. They looked at it for cardiac arrest, shock, and critical care. They had a 4-hour sim training session, and they demonstrated retention at 6 weeks. This is our own simulator room. Here's Jill doing a TEE on this mannequin here. This is a Vimedics here. The second big study looking at training and competency was done in 2017. 40 EM residents. They had 3 times 30-minute sessions plus a 30-minute assessment. They stuck with just the 2 resuscitation views, and they found 95% diagnostic accuracy. And the interesting thing about this study was the time it took from probe insertion to get a diagnosis. So obviously ruling out pathology took longer than ruling it in. So 31 seconds to call it normal. But bear in mind, this is not interrupting CPR. So this is being done during CPR. Asystole, 11 seconds, tamponade 14, acute MI 21, and VFib in 12 seconds. So there have been some other kind of studies, case series published, but the next big sort of publication on TEE was actually a set of guidelines published in Annals by ASEP. Many of the authors that I've already mentioned were involved in this study, possibly a little bit premature, publishing guidelines before we have a lot more evidence, but nonetheless, this is something that's being adopted across many of the larger centers. And one thing they did mention was very well in this set of guidelines were how to set up the program in terms of probe maintenance and cleaning. You know, as you can see, this is the setup that you need for a transesophageal echo program. You need the sort of cleaning system, and this is the leak testage equipment. Leak testage is required to ensure that you know that it doesn't conduct any electrical current either from the transducer into the patient or from the patient into the operator, which obviously when you're running a cardiac arrest is actually quite important. You don't want to find yourself, your sonographer on the floor in sort of V-fib after shocking the patient. So their guidelines reported a number of benefits. They reported reduced interruptions in CPR, higher quality imaging, and continuous imaging. And they had the indications for this were cardiac arrest and peri-arrest. So this is a patient post-arrest. They've been shocked, they're in ROSC, and then the transducer is kept within the patient during that period for continuous cardiac monitoring. So the questions that are advised, so like with many sort of POCUS applications, we tend to try to limit it to a number of questions. And what is suggested is that the question number one is, does this patient have presence or absence of cardiac contractility? Is this PEA, i.e., as I mentioned before, you know, no pulse and no ECG trace and no contractility, or is there some sort of small amount of contractility that we're just not appreciating without ultrasound? Or even, is this fine VF? Can we identify any reversible causes? Here's a case of a patient STEMI, cardiac arrest. This is a free wall rupture, so it's hemopericardium. And unfortunately, this is not a cause, it's just an irreversible cause. And in any case, the CPR is ineffective too. So 3 pieces of information answered on that scan. The quality of the CPR, and then this monitoring. So how do they respond to defib, epi, fluid if they're in shock, lysis, etc. And then this early detection of deterioration in the post-arrest patient. The findings that are recommended that we look for are pericardial tamponade, hypovolemia, pulmonary embolism, acute MI, and other, e.g. dissection. This is a patient with an inferior STEMI. So this patient had pseudo-PEA. This is a transgastric view. And hopefully you can see that there's good thickening of the myocardium anteriorly and laterally, but inferiorly. So bear in mind that the transducer is behind the heart. So this is inferiorly. There's very little thickening here. And this is an inferior STEMI. So I'm not going to teach you how to do resuscitation TEE, but I am going to just introduce you briefly to the views. And we will be having some sessions on this in the near future for people to sign up to. So these are the views that I'm recommending, and I think are occurring in most of the larger centers. So the mid-esophageal 4-chamber, the 2-chamber, and then the transgastric short axis. So the mid-esophageal 4-chamber is obtained by inserting the transducer to the mid-esophageal level. It's a posterior view. So the transducer is behind the heart looking anteriorly. So that's posterior, anterior. That's the left ventricle, the left atrium, mitral valve, right ventricle. There's no tilting. There may be a little bit of rotation required to get the view, but it really is extremely simple to get. Getting the 2-chamber view, which is probably the one that we want to use for actually assessing cardiac compressions, because this is the sort of sternum down here. This is the left ventricle, or the chest walls here, left ventricle, left atrium. And this is where we're going to be able to watch and see how good our compressions are, and also look at the cardiac function. This is obtained using this omniplane control knob here. These are the control dials. So these ones control anti-flexion, retroflexion, and lateral flexion. And this button here controls the omniplane, which actually rotates the transducer in there to get the two-chamber view. So there's a graphic. And then finally, the transgastric view. And this is probably recommended more post-arrest for looking for additional pathologies. Advance the transducer into the stomach and anti-flex the transducer, and then you're going to get this view here. So just to show how quickly it can be done. So it's as simple as just basically pushing it through. Notice the patient is intubated. And first you're going to see a little bit of lung tissue. And then you're going to advance it a little bit further past the great vessels in cross section. And then finally you get your mid-esophageal four-chamber view. It really is as simple as that. In terms of a protocol, what is suggested, having reviewed the literature, seen what other people are doing in their centers, this is kind of a protocol that I think would fit with how we would manage cardiac arrest with TEE here. So ACLS ongoing. If the patient has an endotracheal tube, you're going to insert the TEE sort of on arrival. If they don't have an ET tube, you're going to have to switch out to their supraglottic airway, because obviously you can't get a TEE beyond a supraglottic airway. Don't obviously interrupt CPR while you're doing this, and it's advised that you use video laryngoscopy both for the ET and also to assist with inserting the TEE. Advance the transesophageal echo, visualize the aortic arch as you're coming down, get to your four-chamber view, assess for contractility, assess for reversible causes, then switch to a two-chamber view where you're going to monitor CPR quality, monitor for contractility during pulse checks, etc. Continue ACLS. Obviously, if no ROSC, you stop. If there is ROSC, you're then going to continue to monitor the patient, and you might add additional views during that time. So the largest study looking at incorporating this into practice was published in 2021. This is 42 months worth of work, 52 emergency physicians, mixed level. 75% of their physicians were core trained, they weren't advanced POCUS users. And this was after 4 hours of sim training. They used a similar training model that I described earlier in this talk, just a 4-hour Vimedics and an assessment. They performed over 500 scans, obtained clinically relevant images in 99% of those. The breakdown of their presentations was the vast majority were peri-arrest, either before or after. During cardiac arrest were the next, and there were some patients who were in shock. Interestingly, for 21% of the patients in VF where they did cardiovert the patients, there was no damage. There was no damage to the probe in any of those patients. So, when they cardioverted the patients, they had the probe in place for 21% of them, and there was no probe damage. There was one case of ET tube dislodgement during insertion, but this was noticed at the time because they used video laryngoscopy. There were no cases of esophageal perforation. They did actually notice one case of a malplaced tube, which had been done by EMS when they were putting the the TEE into the patient. So they routinely use video laryngoscopy to pass the TEE, and in one of those cases, even before they got the transducer in, they noticed there was a problem with the airway, so that helped them there. The thing that they mentioned, sort of overarching sort of feeling, was that the peri-arrest state seemed to especially benefit from from the continuous TEE cardiac monitoring, enabling early intervention opportunities. So these were things like noticing the patient was becoming braddy, or noticing that the heart was starting to, the ejection fraction was deteriorating. They were able to start inotropes earlier, and you know, that they felt that helped with their management of the patient. Just to mention the complications, so there are obviously complications in any procedure, and this is a procedure. So airway complications are much more common in pediatrics. They tend to occur due to pressure from the the transducer, so tracheal compression, right main stem advancement of the ET tube. So you might push the tube further in as you advance the TEE, and extubation may occur. But again, these are more common in kids than in adults, and even then they are, you know, pretty rare. And the esophageal complications are exceedingly rare, and even these reported numbers occurred during comprehensive TEE examinations. So these are where they get 20 different views. There's a lot of probe manipulation, a lot of anti-flexion and lateral flexion within the esophagus. So exceedingly rare in our group of patients. They recommended in their incorporation to practice in that study, for maintenance of privileges, they looked at performance of 2 scans per year. And if you didn't do that, you had to have a SIM refresher course. And so this is the number of scans across their faculty. I thought this was interesting and maybe worthy of further discussion for some of our other halo type procedures. So just the case continued. Are we doing continuous, are we doing effective CPR in this patient? And the answer is no. Here's the left ventricle. This is the left ventricular outflow tract. Essentially what's happening here is we are obstructing with each CPR, we're obstructing the outflow tract, and not really helping with flow in that patient. So this actually is more common than we thought. There's a number of studies that have shown this is a relatively small study that showed that this occurred in 50% of patients in out of hospital cardiac arrest, in terms of malpositioning of CPR. So the patient is now getting decent CPR. We've got valve opening. Notice how the mitral valve closes during CPR. There's a quick pulse check, see during this pause whether there's any contractility. But unfortunately, the patient then flatlined, but luckily for the patient, we did have the transducer in place. What do we see here? So this is fine VF. So this patient has, we've got these fine little twitchy movements occurring within the myocardium. And this patient obviously needs to be defibrillated. I must say I do miss these old pads. Maybe that's me being old, Paul. I'm sure Paul misses them as well. So just to summarize, that was a sort of a quick review of transesophageal echo in resuscitation, reviewing the utility. It is well established in a growing number of larger centers. More research is needed, obviously. We do need some larger scale observational studies, and also some outcome studies, for example, TEE guided CPR versus standard CPR. But if we are going to use it, and I'm recommending that we do follow the stepwise approach. Insert at the time of airway management, look for cardiac contractility, look for reversible causes, look for CPR quality, and then continuous monitoring. And it really is very easy to learn, and it's safe. There's the references, and there are some resources there. You can photograph that slide, and then you can then access those in your own time. So thank you very much for letting me present to you today.
Thank you so much, David. Really world-class introduction to transesophageal echo and also ultrasound monitoring during cardiac arrest.